However, we use the system, these basic rules when you're addressing priority situations. So the first one, of course, is ABCs. You deal with airway, breathing, circulation issues first. But sometimes that's not even what's being asked, meaning that's not even an option. So if it's not airway, breathing, or circulation issues, then you move on to your Maslow's hierarchy of needs. And this is a hierarchy when you address physiological issues. It could be something like the patient has to pee. Peeing or defecation is part of physiological factors, so that you would address those components first if it's not ABCs. Then you deal with like safety measures, maybe bringing the patient who's getting out of bed closer to the nurse's station. That would entail like a safety issue. Then belongingness and love, so you can build up self-esteem and self-actualization. But these bottom two are probably the most important ones, that you deal with physiological issues as opposed to, before you address any safety issues. Above everything else, though, airway, breathing, and circulation is priority. Also, I'm assuming that he's going to have a scenario where the patient's in bed and suddenly they have a sudden change of level of consciousness. If that's the case, then you want to find out if they have circulation. I hear that he was addressing something along the lines of you assess the carotid pulse. The carotid pulse lets us know if there's perfusion to the brain. So maybe that's it. Again, I don't know. But these are the rules that you use to figure out what to prioritize. Also, remember that you always want to prioritize systemic issues before you address localized issues. So if a patient was exposed to the environment outside during really cold weather and they are experiencing hypothermia as opposed to frostbite of the left hand or wherever would be a localized issue. Hypothermia would be a systemic issue. So you would prioritize the hypothermic patient or the hypothermia before you address any issues dealing with the frostbite. That would be an example of addressing systemic issues before localized. Then we always treat acute issues before chronic issues. So if you have two patients, one of them has an MI, or let's say one of them has angina, and the other one has fatigue because they have a history of heart failure. Well, heart failure is a chronic issue as opposed to someone developing angina, which is more of an acute issue. So you would address that thing first. Then when it comes to problems, you always address actual before potential problems. I think that kind of goes without being said. What's really important too, when they give you like a bunch of, for these next gen questions where they give us the little tabs that we can click on, they're going to give you a list of a variety of vital signs and things that are happening with the patient. You want to be able to recognize trends. What I mean by that is for instance, like if we're talking about ICP, intracranial pressure, which is your brain starts to swell up. Normally you have the classic symptoms of ICP is what we call Cushing's triad or Cushing's response, where you have a widened pulse pressure. That's where the systolic goes up and the diastolic either goes down or stays relatively the same. This is one of the big things that you'll notice with someone who has ICP, right? So let's say at 9 a.m., the patient comes in and their blood pressure is 128/78. Is that a bad blood pressure? No, it's probably better than mine. But then like at 10 a.m., you notice that the patient, it's 132/72. And then at 11 a.m., it's 138/70. What we're noticing here, individually, they're not that big of an issue. The blood pressures are all pretty decent. But you'll notice the trend that the pulse pressure, the difference between the systolic and the diastolic, it's separating, meaning it's widening. That's what I mean by look for trends. You want to look for jumps in temperature. You want to look for drops in blood pressure or increase in blood pressure, whatever the case may be. I'm using the example of ICP, but there could be a variety of scenarios where you want to look for trends as opposed to absolute numbers. So just make sure you guys know that. Then you want to recognize complications as opposed to expected findings. If a woman's pregnant, they experience hemodilution, where the body retains fluids and the hemoglobin becomes diluted. So it's not abnormal to see a woman who's pregnant that has a 10.5 hemoglobin. That's okay, as opposed to someone who has a history of bleeding, let's say, and their hemoglobin dropped. Yesterday it was 14 and today it's 10.5. That trend, that huge drop, that's something that we want to look at. Even though it's still within the normal limits, that big drop is something that we're going to look after, as opposed to that woman who's pregnant, which we know they experience hemodilution, and that would be okay. But the sudden drop in those values in that other patient, that's something that you really want to consider. That's what it means by complications as opposed to expected findings. Then when you have a question that gives you a bunch of a scenario where like there's some potential complication going on, like what do you do next? A lot of times we want to report it, but remember, unless it's an absolute emergency, you want to assess before report or before you intervene. Because if you're going to report something, well, you have to collect data so you can give it to the doctor, so he or she can give you some interventions based on the parameters that the patient's experiencing. So usually, unless it's an absolute emergency, you want to assess before reporting or before intervening. And then you also want to consider your stable versus unstable patients. We always treat the stable ones before the unstable ones. That also goes without saying. And when you're performing interventions, normally you want to start off with least invasive, more patient independent, things that the patient can do on his or her own. For instance, if the patient has a pain that's 5 out of 10 pain scale, what would be your initial intervention? It would be more like do guided imagery or something that the patient can do by him or herself before we start talking about giving them medications to remove the pain, analgesic. So you always go with least invasive, least intrusive before you do the interventions that are more intrusive or more invasive. And then the whole BLS thing was based on the scenario that Professor Wynn was bringing forth, where if you have a patient who's unresponsive in a hospital setting, we use BLS. And if the patient has some type of cardiac issue, then we use ACLS, which we'll discuss at a later point, I'm assuming. You good?